we'll just start.
Mhm.
Uh, so hope everyone gets a chance to take a look at this webinar that we're running today. And the topic is esophageal cancer. I am interested in this new technology because, well, one, a relative, and second, a neighbor, both were diagnosed with esophageal cancer over the last few years. In fact, one within the past year, and the other one 5 years ago. And what was striking is how they had very minimal symptoms, and then there was significant aggressive disease. My cousin died within 2 years of his diagnosis, and our neighbor has just gone through extensive surgery. And the thing that we talk about is the use of over-the-counter antacid medications for symptoms of reflux. And so I've invited Dr. Victoria Lee here today from Lucid Technologies to talk about esophageal cancer, the impetus behind the development of this technology, and why Lucid Technology feels that this would be a real game changer for people diagnosed with esophageal cancer. Its survival rate is possible, but not without enormous um, just health issues going forward that are almost insurmountable. I have so many people that have gone through their esophagectomies and had to deal with radiation and chemotherapy. It's an exhaustive, enormous toll to both the patient and the family. So hopefully that this will provide us with very early diagnostic screening. And she will go through why this technology was important and some of the statistics around esophageal cancer. As you know, reflux symptoms have been increasing because we have increased obesity. We have drugs that are decreasing the ability of the esophageal sphincter to respond to changes in the gastric mucosa and the messaging from the gastric mucosa up to the esophagus. I've been particularly interested, Dr. Lee, in the effect of PPIs and actually raising the pH and maybe even causing more reflux because the esophageal sphincter is becoming desensitized because of that signaling. There was an elegant study in Japan looking at reflux and the gastric signaling and found that patients that were on long-term, meaning years of antacid therapy, actually did not have a decrease in the prevalence of esophageal cancer. So, without further ado, Victoria, thank you for joining us, and I'm really excited about the technology that's being developed.
Thank you very much, Dr. Hopkins, and thank you to your group for taking the time to listen to our webinar today. I appreciate the opportunity to be able to talk a little bit more about the technology that my company, Lucid Diagnostics, provides and makes available to patients, as you mentioned, in this field of screening for not just esophageal adenocarcinoma, but also the precursor condition, Barrett's esophagus, which many patients don't realize is the only direct precursor to esophageal cancer, but can now be very readily treated in an endoscopic fashion.
So, I guess
So
one of my first questions would be, do all esophageal cancers have the precursor to Barrett's? And
that's a
like,
that's a great question. So there are two major types of esophageal cancers here in the US and also in Western countries. About 80% of the esophageal cancers that we'll see are esophageal adenocarcinoma,
right.
whereas in Eastern countries, China, Japan, Korea, squamous cell is much more common. And that one is not what our test is intended to detect. We are a molecular biomarker that's specifically designed to identify epigenetic changes that are the hallmark of intestinal metaplasia that is key to Barrett's esophagus and also would be seen in esophageal adenocarcinoma. That also ties into an interesting bit of data that was published very recently as well about esophageal adenocarcinoma, in that sometimes you'll see patients who are diagnosed with small patches of cancer, and they may not necessarily be present within a bed of Barrett's esophagus. The presumed reason for that is that the cancer has actually overtaken the previous bed of Barrett's esophagus, not that it developed de novo without the precursor condition, but rather in some patients, the cancer has taken over the entirety of the irregular tissue so that there's no more Barrett's left. But all of the cancer has essentially manifested in the previous area of disease. So there was a precursor, but now it's all just present as cancer and there's no earlier stage disease left. So let's go ahead and get into some of the details that Dr. Hopkins had mentioned we'd be discussing today. So I'm the Chief Medical Officer at Lucid Diagnostics. We develop and we also commercialize a technology called EsoGuard, which is a molecular biomarker-based test for the detection of intestinal metaplasia, dysplasia, and also esophageal adenocarcinoma. And as I mentioned before, the intestinal metaplasia and dysplasia is what precedes the cancer. And what's exciting about this technology is that it's really quite an advancement because historically the way that disease was diagnosed was purely endoscopically, which is quite invasive and it requires time out of someone's busy schedule to undergo the sedation that's required for endoscopy, then the recovery period, which often ends up losing about a day of work. That is the premise for why we believe a lot of patients don't typically undergo screening, even if they would be considered high risk based on well-established risk factors.
Well, I think there's also the transformation from Barrett's esophagitis, and you feel that you are, quote, in control on your medications, but nobody can predict the delta to the cancerous stage based on a given endoscopy. I make the analogy it's like a stress test. Just because you pass this stress test on the treadmill doesn't mean that you won't die of a heart attack within a week of that stress test. And I think that's always been the struggle, which is yes, right now we don't see cancer, but that doesn't mean it won't be there or could not be there in 2 or 3 months. And I don't know if you have a sense of that time frame. Is once a year adequate for that kind of surveillance?
You make so many great points, and it also touches upon what you had mentioned earlier about this false sense of security in patients whose reflux symptoms are well controlled on acid suppressive medications. We can go over some of the details about the cadence and frequency of screening a little bit later on,
Hmm.
but you're correct in that it is going to be tailored to the patient's specific diagnosis. Someone with early stages of Barrett's esophagus, lack of dysplasia, and short segment disease would undergo surveillance at much wider or stretched out time intervals than someone with long segments of disease who have a lot more abnormal tissue that could potentially progress.
Hmm.
And especially those who are manifesting signs of dysplasia, we often don't survey those. We just go ahead and treat them immediately because depending on the stage of dysplasia, the progression rate annually could be anywhere between 2% to as high as 11% in the
Yeah.
literature. So we really don't want to take the risk by just waiting on those patients.
Hmm.
As far as the technology, I mentioned very briefly that it's a molecular-based test, which means that it can be performed non-endoscopically. So in contrast to historically when screening was done endoscopically, we can now do the test in office, whether it's in a primary care provider's office, in a family medicine provider's office. It can also happen in a GI's office, but by the time you're being referred to a gastroenterologist, chances are you're going to be scheduled for an upper endoscopy at that point anyways. Really the amazing shift is that it can be done so quickly and non-invasively now that anyone can do it. And it's just way more accessible than endoscopies used to be,
Hmm.
especially taking into account that we're fortunate enough to live in cities where resources are quite readily available. In Boston, we have some of the best specialists in the country, but when we think about the rest of the US, there's huge swaths of the country where it's very hard to get access to a specialist, including gastroenterologists for an upper endoscopy. And so to rely on that as the only source of screening starts becoming really difficult for those patients who just don't have the same level of access.
Well, relative to the other point, which is what is the delta between and how do you rate the progress from point A to point B, is that we are now backed up at least 6 months for screenings. And that also can be a significant issue when patients are, and I'll let you go through, how do we identify the high risk patients?
Yeah. So as Dr. Hawkins had mentioned, and we discussed briefly, esophageal adenocarcinoma is really the type of esophageal cancer we'd like to focus our webinar on today because it is really the most prevalent type of cancer here in the US and other Western countries, making up about 80% of all esophageal cancers. And what you'll see on this graph is that in contrast to a lot of other cancers that perhaps get much more press, whether it's breast cancer, colorectal cancer, prostate cancer, esophageal adenocarcinoma had seen a pretty steep rise in incidence between the 1960s to the 2000s. Part of that is probably due to increasing risk factors, which include obesity, tobacco smoking. But as Dr. Hopkins had mentioned, with proton pump inhibitors and other fantastic medications that have gotten really good at controlling patients' reflux symptoms, now patients who would normally be undergoing evaluation because of their reflux symptoms, if they're well controlled with prescribed or over-the-counter medications, there's no longer the same impetus to drive them to undergo the traditional screening modality, which is upper endoscopy. So now the vast majority of patients are being diagnosed late because by the time you manifest symptoms of cancer, you're usually at a advanced stage, whether it's stage 3 or stage 4.
Hmm.
Now, the sad thing is that even when diagnosed at a localized stage of disease, so stage 1 or stage 2, the 5-year mortality rate is still close to 50%. And that's primarily driven by the fact that even in stage 2, this cancer is highly, highly lethal despite advances in chemotherapy and biologic agents.
So
So
50% 5-year survival puts it at one of the more aggressive um,
yes,
cancers, and probably gastric cancer exceeds that, pancreatic cancer exceeds that.
exactly, spot on. So when we think about the top 3 deadliest cancers here in the US, based on the 5-year mortality, as Dr. Hawkins said, pancreatic cancer, everyone knows is the worst. It's really the overall 5-year mortality rate is you're getting very close to 85%. Esophageal adenocarcinoma and hepatobiliary cancers are essentially tied for second worst, and they round out the top 3. And with all of these cancers, again, diagnosing at an earlier stage is still not effective in guaranteeing long-term survival. Fortunately, with esophageal adenocarcinoma, as I mentioned, we have a easy to diagnose precursor condition, which is actually incredibly easy to treat now. When you have Barrett's dysplasia, the treatment for that is actually endoscopic. In the past, esophagectomy was the primary route of treatment to avoid progression of cancer. Now, if we get to keep our esophagus, your GIs can actually just perform radiofrequency ablation or cryoablation with a few cycles of therapy. About 90% of these patients will be saved from progression, and their risk actually goes back to baseline after being
Mhm.
fully eradicated. And that's what makes screening at this point so much more effective. I'd
Now,
say
is
this
there
to
a
give
level of dysplasia that you tip over into having the ablation done?
Yes, that's a great question. So there is. Now, with high-grade dysplasia, everyone, the recommendation is for endoscopic eradication therapy immediately because that's the stage where the annual progression risk is somewhere between 8 to 11%. With low-grade dysplasia, the guidelines also recommend endoscopic ablation therapy in patients who don't have major contraindications, such as those patients who are not so old and don't have such comorbid conditions that they can't tolerate the procedure, because that annual risk of progression, although lower than high grade, is still somewhere around 2 to 5% per year, depending on which article we're citing. So
Mhm.
that's not an insignificant amount. Whereas those patients with non-dysplastic disease, those get surveyed, and the frequency of surveillance is going to depend on whether they have a short segment of disease or long segment, with the underlying premise that the more disease you have, the more tissue there is to progress, and so their risk is going to be higher if you have long segment disease than if you have short segment. So it's either 3 years or 5 years. Now, the target as for who we'd like to screen, although it's still valuable to detect patients at the high-grade dysplasia stage, the vast majority of patients, if you're screening them at a snapshot in time, are going to be diagnosed at a stage of non-dysplastic disease, just because that is much more prevalent than dysplasia. But that's still critical because, as Dr. Hawkins had alluded to, the best way to diagnose incident dysplasia is by surveying those with non-dysplastic disease because there's going to be progression over time. We know that this stepwise fashion of disease progression is the paradigm by which esophageal adenocarcinoma is develops. And so the key is to really just identify when patients are starting to progress, when they hit the dysplasia stage, so that we can treat them before they get to cancer. Now, in regards to the patients who are at risk, I mentioned before that the vast majority of patients who are at high risk don't get endoscopic screening. But that's approximately 90% of those patients who would meet guideline criteria for screening don't generally undergo upper endoscopy. And the ones who do are usually referred because they're that handful of patients with reflux symptoms that are not actually well controlled with their medications. So the primary driver of why someone might undergo an upper endoscopy is usually because their PPIs aren't working and they want to figure out what a good solution would be for their uncontrolled symptoms. But when you look at the gastroenterology guidelines here in the US, the population that ought to be screened, those who are at risk for developing esophageal adenocarcinoma and its precursor, Barrett's, is a much broader population. So those patients with heartburn, we all know that the predisposing pathologic impetus for development of this disease is chronic reflux. Those patients with chronic heartburn, that's one of 7 risk factors. Males are at higher risk than females, although it's not impossible for women to develop this disease. Those over the age of 50, because it is a disease that's more common in older individuals. Although, again, we are starting to see some younger individuals develop cancer. White race, which is why this is more common in Western countries. Those who have a tobacco smoking history, whether they're current or former smokers, obesity, and perhaps most importantly, a family history of either esophageal carcinoma or Barrett's esophagus in a first-degree relative. Now, I say that most importantly because in that specific cohort of patients, we can see incidence rates of upwards of 20% developing Barrett's esophagus and being at significant risk of esophageal adenocarcinoma if you have a first-degree relative. So those patients should definitely be screened.
Hmm. So I see this falling into the category that we now use for low dose CT for lung cancer.
In that there's a
They're over
well-defined
50, they have a
population.
history of smoking. I mean, I'm looking at this going, well, all of those people, I'm now doing low dose CT scans to find early stage lung cancer. And it would seem to me that that same progression, whether it's you're looking at prostate cancer, breast cancer, lung cancer, esophageal cancer, is something that we've had on the sideline and waited till it was clearly a stage, as you said, stage 3 or 4 disease.
Yeah, I think that is a good way as and knowing how busy providers are nowadays, if there's a way to kind of group patients together to help make it easier to remember who should be screened for which diseases, I think that's a great parallel. The other thing is when we look at patients who are being referred for screening colonoscopies, we often don't think about it, but a lot of the patients that we see are going to meet a lot of these other risk factors. If they're over the age of 50, chances of them being white and male, now they've already hit 3 of the risk factors. Over a third of our population is obese. So there's going to be a very high probability as you're looking at which patients you're sending for screening colonoscopies, that a large percentage of them should also be considered for screening for Barrett's as well. And there was actually an interesting study that came out of the VA a few years ago where they did exactly that. They looked at their screening colonoscopy patients and reviewed their risk factors. And the patients who met criteria for being high risk for Barrett's were also sent for an upper endoscopy at the same time. And they found quite a lot of disease, very consistent with what the expected prevalence would be in this high risk population, which was
Hmm.
over 15%.
Oh.
So that is thinking about them in these broader categories of
Hmm.
screening and just figuring out who to group together makes it a lot easier to identify those at-risk patients.
Hmm.
Now, you did bring up the low dose CT for smoking. That's a good segue into the guidelines actually that recommend screening for esophageal adenocarcinoma and Barrett's. So low dose CT scan is endorsed by the USPSTF, which is great because that makes it easy for most primary care physicians to remember to order this test. Barrett's esophagus and esophageal adenocarcinoma, the prevalence of disease is not so high as to be considered by the USPSTF. And there's the added element that it's really not a general screening population that we're targeting for screening. There's a very well-defined high-risk population that is quite a bit smaller than the general screening population, depending on which US GI Society guidelines we're looking at. So the American College of Gastroenterology has perhaps the strictest guidelines. They recommend screening for those patients with reflux, as we saw on the other slide, and 3 or more additional risk factors. And this was a balance of identifying the most high-risk patients while not overtaxing available resources,
Right.
and knowing that it's really in a country with the healthcare system that we're operating under, resources always must be a consideration. But there is a knowledge that when you're sticking to such a strict population, there's a possibility of missing patients who might eventually develop cancer because reflux symptoms are not always a good predictor of who actually has reflux, especially if there's underreporting from patients. And there's also just atypical reflux symptoms that most patients would not associate with that disease process.
Mm-hmm.
So the American Gastroenterological Association took a slightly more liberal position in regards to who they recommend for screening based on risk criteria. And their recommendation is that anyone with 3 or more risk factors, it doesn't have to be GERD plus 3, it could be GERD and another 2, or combination of any 3 of the others. That would be a screening population that would be wonderful to target and would be the most sensitive for detecting everyone who would potentially develop cancer.
Right,
But that
because
would
once you've
cause
done that screening, that patient then moves on to, if it's positive, they move into the endoscopy slot.
Yes, so it's going to be a more resource intensive strategy, but it would be guaranteed to catch everyone who's going to develop disease.
Hmm.
Now, the NCCN this year, for the first time, had actually put screening guidelines for Barrett's esophagus and esophageal adenocarcinoma into their guidelines for esophageal and gastric cancers. And they actually included both the ACG and AGA's recommendations within their guidelines. So it's really
Hmm.
up to the provider and their patient population as to who they would want to target for screening. But this is the first time that the NCCN has actually included screening guidelines for this disease state within their own recommendations. And I think that's making great progress because in the past, they really just focused on cancer itself and not just
Right.
precancer. Now, the most important thing about these updated guidelines is that guidelines for screening for Barrett's esophagus have been around for decades, but in 2022 was the first year that they included non-endoscopic strategies within their endorsements for screening. And included within those strategies are our test, which is using our non-endoscopic cell collection balloon device called EsoCheck with our biomarker-based test called EsoGuard. And so they recommended EsoGuard as an alternative to a screening upper endoscopy for those patients who either are not likely to comply with the endoscopy or would like a non-invasive alternative as a first step. And the way it works is to go ahead and get tested with EsoGuard in the office as a triage to more invasive EGD. So it can be done in the office. We say that it's about a 3-minute cell collection time, although looking at our statistics, it's really closer to 1 minute to do the cell collection itself. It doesn't require any sedation. It's just a swallowable silicone-based balloon capsule device, and it's highly sensitive, as we'll discuss in later slides when we talk about the performance characteristics.
Hmm.
But what I think is most important is that the way it's intended is to help providers decide who really needs an EGD and who doesn't. So the results come back binary. Either someone is positive, meaning that they have the aberrant methylation to suggest some cellular changes that need to be further evaluated, or it's negative, meaning that they didn't meet the pre-specified threshold and their likelihood of having disease is incredibly low. So we can rest assured that they're negative and they don't actually need another endoscopy. And that helps as far as resource utilization, but also expanding access to screening for a lot of patients for whom getting an EGD is not so easy.
Hmm.
And as physicians, everyone wants to be reassured of the safety, and there's been over 40,000 of these tests done to date in the last approximately 2.5 years, and there's been no adverse events associated with testing that have been reported at
Yep.
all out of those 40,000, which is really important too. So
Now,
this
there
is
are a
really,
lot of companies that are coming out with DNA testing for many cancers. Does this in any way correlate with a company like Guardant or Galleria?
yeah, so that's a great question. When they with these tests that are focused on early cancer detection, and most of them are multi-cancer early cancer
Right.
detection, the data is really important. And so the most published is Gallery's test.
Hmm.
And when we look at their data, they had the Pathfinder study, which was published a few years ago. More recently, Pathfinder 2, the early data was presented at the European Society for Medical Oncology. That was in October, I believe.
Hmm.
And there was both good things and bad things that came out of the data. But I think the most important distinction to make before we talk about their data is that their focus is on early cancer detection under the premise that if you detect cancer early, it tends to be more treatable and patients tend to do better depending on the type of cancer. For us, our goal is not just detecting cancer early. We really want to detect it at the precancer stage because with this specific disease state, the precancer is treatable so that we can avoid cancer altogether. So
Hmm.
our tests are actually quite different. We're not really competing in the same space because there's a lot of cancers out there for which a precursor condition is not easily diagnosable. And so the idea of being able to prevent cancer is moot. We really want to focus on that prevention element. Um, for the MSET test, though, there are some things that they do really well. Galleries shown that now when patients come back with positive signals on their test, the ability to pinpoint where that positive signal is coming from is incredibly high. I believe their first publication showed 75% ability to pinpoint where it's coming from. Now they're up somewhere around 90%. So there are
Wow.
major advances in their technology that are fantastic. And they also talked about how the majority of the cancers that they detected in Pathfinder 2 were cancers that would not have been detected based on current USPSTF screening. So
Hmm.
there were 133 patients that were true positives from their multiple thousand patient study. And the vast majority of those were not lung or colorectal or other or breast or cancers that we typically screen for. They were able to detect cancers that otherwise wouldn't have been detected because people don't have a normal test to screen for them.
Hmm.
So that's also promising in that, there's there's someone trying to develop a technology to really help diagnose cancers that people aren't often thinking about.
Right.
Now, the
Because if you can
bad,
see it, it may be too late.
yeah, well, but now the bad is that the false negative number was 196.
Hmm.
So there were 133 patients where they detected cancer that, some of it might not have been otherwise detected. But then there were 196 patients who were told they didn't have cancer and then found out later that they had cancer.
Wow.
And we have to question what types of harm we're doing there.
Right, right.
And
No, I think it's a difficult when you're in the clinical practice because you don't want to go down the rabbit hole. And, we deal with screening issues all the time, from mammography to pap smears. You end up generating a tremendous utilization of resources in which the truly positive shrinks over time, but you're chasing more and more. The digital mammogram has shown us that. We're finding more and more people with DCIS stage one, and we don't see a huge shift in mortality overall. And so I think that's the cautionary tale, whether it's garden or gallery, that I think there still has to be a fine tuning, and perhaps it's
yes,
surveilling people who have had cancer. I have patients with high risk cancers who I recommend that screening because they're now getting CAT scans every 6 months. And I'm like, no, I think I would do the DNA test because when we find it recurrent on your CAT scan, it's too late.
yes. And
So
I
I've
think
narrowed
you're,
that focus, but this is for me in my practice, again, equivalent to what we're used to, where we do pap smears, in which we find a very early stage, and it's become a yearly screening criteria for population health, where I see this joining that as something in high risk populations. It is what you do.
Yeah, yeah. And I think the way you're thinking about it is the way that most physicians who are really knowledgeable in this space are thinking about it, is that these tests are great and the innovation is amazing, and I can't wait to see where we are in the next 20 years. But it's really where it is right now is better for tailored populations, specific
Right,
cohorts like you were talking about, and
right,
not necessarily for the general population screening.
right,
It's not quite ready for prime time if we're
right.
thinking about using it to test everyone. So in regards to where EsoGuard fits into the patient care pathway, there's a few slides that really show you where it fits in, because this paradigm of screening has been around for a long time, as I mentioned, but traditionally it was endoscopy. So now EsoGuard as a non-invasive test would actually precede endoscopy. We have a well-defined high-risk population that gets tested, and those who are negative, there's nothing further to do. As I'll discuss later, the negative predictive value for EsoGuard is 99%. So we
Mm-hmm,
can be very confident that if a patient comes back negative, those are true negatives. And we don't have to subject them to an endoscopy to really tell ourselves that.
mm-hmm,
For those who are positive, though, because it's a binary test result, those patients have some sort of cellular changes that warrant additional workup. And the way to really distinguish what those changes are will still be to undergo the traditional gold standard diagnostic test, which is upper endoscopy. So those patients end up getting an EGD, and they'll get staged based on their biopsies to either non-dysplastic disease, like we mentioned before, they'll get surveyed, or dysplasia, in which case they'll get ablated. And those who unfortunately have cancer, chances are, if they were asymptomatic and they're just undergoing screening, our goal is to have detected that cancer at an early stage and they get treated, and still hopefully do better than those patients who don't present until they're symptomatic with dysphagia or other signs of advanced
mm-hmm.
disease. But in this paradigm, about 70% of patients are going to test negative. So now you can screen a lot more patients, but using a lot fewer upper endoscopies to get us to the point of diagnosis. Just a few points, because we always have questions from providers about what the experience is when we're doing the cell collections themselves. I did briefly mention the EsoCheck cell collection device, which is how we get the samples to our lab for testing. And this device is FDA 510(k) cleared. As I mentioned before, there's been no serious adverse events associated with the cell collection to date. But what is really reassuring, I think, to providers is knowing that this device is made of silicone, so it's incredibly gentle. When it's swallowed by the patient, the balloon is actually encapsulated within a capsule that's about 3/4 of the size of a multivitamin. So the vast majority of patients don't have any difficulty swallowing it. We have about a 96 to 98% success rate, depending on who's administering the device. And it takes less than 3 minutes on average, but really in the hands of an experienced provider, it can take between 45 to 60 seconds to get the cell
Mm-hmm.
sample. And the beauty of this is that because the cell sample's on the surface of the balloon, and we retract the balloon back into the capsule before we withdraw the device, we can really target the distal esophagus for sampling, which preserves the methylation signal and protects it from any sort of contamination or dilution as we're taking out the cell collection device. But also B, because the balloon's withdrawn and it's back in the capsule, the device comes out the same way that it went in. So it really is quite easy to tolerate, because if you were able to swallow it, chances are it coming out is going to feel just as easy and smooth. And I've had it done myself, and it really was not difficult at all.
Well, when I was teaching medical school at NYU, you couldn't graduate from my physical therapy course until you did a um, put in an NG tube. Medical students would just sit in with each other for about 5 hours going, you do it. No, you do it. You had
I'm
to
so
start an
glad we
IV, draw our blood, and put down an NG tube and say to each other, this isn't going to hurt at all.
I'm so glad I didn't have to do that part. The IVs we practiced on each other, I think at some point they stopped forcing us to do NG tubes on each other because
Yeah.
that is the one bedside procedure that really looks
I
so
was so good
uncomfortable.
at it. I could get it. I would tell the medical students, I'll have it down there before you're even blinking. But you know what? When you do it yourself, when you experience it, you can talk a patient through it. And so I was happy to hear that there's probably nobody alive that wasn't as a child trying to swallow balloons when they were little. So
Yeah,
with or without the swing,
I
the
can't
string
attest to the
attached.
NG tube.
Yeah.
But this
Yeah.
one I can tell you is easy and I'm pretty squeamish. I don't know if I had to get an NG tube, I'm going to ask that you do it, knowing that you're really good at it, but I am still not sure that I would volunteer for
Yeah.
one. And this is just what the results look like. So for
Okay.
our primary care providers, internal medicine providers, we make it just really straightforward as far as the binary results
Hmm.
with positives and negatives. The positives go on to endoscopy and the negatives just get managed for their ongoing risk factors. Now, I always like to take a pause after like the discussion of the disease state because it's nice to think about the patient itself and the very real impact that we can have by screening these patients. So there are a few cases that I wanted to highlight that are actually real world cases from our most recent experience with screening. And one of them is actually in a relatively young patient. So he is a 48-year-old male, but he had a lot of risk factors. He was obese, he'd had chronic heartburn, he was on proton pump inhibitors for many years. His primary care doctor had tried really hard to get him in for an upper endoscopy because he wasn't that well controlled on his anti-acid, his anti-reflux medications.
Hmm.
But he was well enough controlled that he just didn't really want to undergo a procedure. And he'd consistently refused the EGD for somewhere between 3 to 5 years. And
Wow.
finally, when EsoGuard became available, she asked him if he was willing to do the in-office test. And he said yes, because he was willing to get procedures done in her office because he trusted her as his internal medicine physician. He just didn't have a whole lot of trust for other physicians.
Yeah.
So she did in the office. She tested him there, and lo and behold, he came back positive. And because he came back positive, and he knew what the test was trying to identify, which was the cellular changes, that positive result was a pretty strong data point to convince him to actually undergo the EGD. So he did actually go through with the EGD after getting the positive EsoGuard result, fortunately,
Mhm.
because his EGD showed that he had a small patches of intestinal metaplasia and a distal nodule in his esophagus that he couldn't feel. And
Wow.
so the initial diagnosis when they biopsied him was high-grade dysplasia, which he got referred to a expert endoscopist to treat. Now, this expert endoscopist, having seen the pictures from the previous endoscopy, was a little bit suspicious that it might actually be worse than high grade. So they scheduled him for an endoscopic mucosal resection, not just typical ablation therapy, as well as adjunctive radiofrequency ablation. And it's very fortunate that they did that because the pathology result from the endomucosal resection was actually T1A cancer.
Oh,
So this
wow.
pay, yeah. So lots of great doctors that he had in his life. Very fortunate there,
Hmm.
in that they all did exactly the right thing to ensure a good outcome for him. But also really fortunate that he caved when he did, because that T1A cancer in a few months probably would have advanced and been invasive. So he's actually completed his treatment and he is disease free. I am happy to say. He had a 1 year follow-up very recently. We spoke to his primary care doctor and he's still disease-free. So this is a fantastic win. We love sharing this story because
Hmm.
it's a patient who ended up doing really well.
So I could see sending out with our newsletter a self-test that would rate the risk so that patients, I don't know if you have that in a format, so that if you get a score of over 10, you have a high likelihood that you are at risk for Barrett's esophagitis and you should schedule this. If you're a 1 or 2, continue to follow, but understanding that the PPIs can be shifting your risk symptoms.
Yeah, we have a symptom checker that we can definitely share. A lot of our providers who use it in the office found it useful. So they
Mm-hmm.
have the patients just report how many risk factors they meet, whether it's their age, the fact that they were a
Sure.
previous smoker. And it'll vary provider by provider which ones they'll really push for screening. So some providers will say if you meet ACG criteria, meaning you have reflux and you have 3 or more risk factors, we really, really advocate for you to get tested. And those who don't, they can just reevaluate on an annual
Mm-hmm.
basis depending on whether or not the risk factors change.
Sure.
And some are more liberal and they go with the AGA risk criteria, but we're happy to share that symptom checker
That'd
if
be
it's
great.
something that would be easy. Um, and then one more story before we go on to just the data, which I know most of you guys are most curious about. This one is another great story, and I like it because we had a younger patient in the previous story. This one's actually an older patient. He was 75 years old, and he actually had reflux symptoms for a long time, over 15 years, but he was well controlled on PPIs. So his symptoms never really bothered him because the medications worked really well, which is how he ended up at the age of 75 and had never undergone an upper endoscopy. This really great guy, he's a retired firefighter. There's been some literature out there to suggest that firefighters, because of the exposures as part of their occupation, may
Mm-hmm.
be a special risk category as well, although they're not specifically called out in GI guidelines. So he met ACG guideline criteria for screening, and he had the addition of potential occupational exposure. So we weren't entirely surprised when he tested positive, because he really does fit that highest risk category.
Mm-hmm.
But what was interesting was that on his upper endoscopy after his positive test result, he's another one who had high-grade dysplasia. And high-grade dysplasia isn't terribly common, but this have 2 great stories here. So he
Sure.
underwent endoscopic ablation therapy. And so this is also great news because he had advanced precancer, as we would call it. And now he had completed his treatment. It sounds like his last EGD, they have a surveillance one at 6 month and then 1 year intervals. His most recent EGD was completely clean of disease. So this was another nice save. That's not his actual picture. I think we pulled that
I
offline
thought
just
it
to
was,
respect
he's
patient
kind of good
privacy.
looking.
Yeah, I was like, I should mention that because of HIPAA, we're not using real photos. This was
Yep.
just a stock image photo, but he looked like the image of a retired firefighter. So now for the part that everyone loves, as clinicians, everyone likes to look at the data. So there are 4 clinical validation studies that have been published to date that show the performance characteristics of the test. And so the ones on the left-hand side are case control studies. So these are studies where the patients had known disease and we tested them with EsoGuard to compare their EsoGuard results with their known EGD diagnoses. And we did the case control studies just to make sure that we were able to detect both Barrett's and cancer.
Sure.
Because cancer is so infrequent that if we were just to do a study in a screening population, you wouldn't get too many cancer patients.
Mm-hmm.
And
So
on the
it
right,
doesn't, the test does not tell you you could have cancer.
no, it just
Only
tells
using
you
the methylation technology for
exactly.
abnormal cells.
Yes, that's why it's a triage. So it tells you that there's something abnormal going on with the DNA in the esophageal cells,
Mm-hmm.
but the EGD would be the step to confirm which stage of disease that they have.
Yes.
The 2 studies on the right-hand side are true screening studies. So these are the ones where we took patients with risk factors. We tested them with EsoGuard and then did an EGD on them to find out what their true disease diagnosis was. And so the data here would be replicating what we would expect real life use to look like.
No,
So
pretty close.
yeah, so the nice thing is that across all of the studies, the performance characteristics are pretty similar. A few things to highlight are the sensitivity for any kind of disease is right around 90%.
Mm-hmm.
Um, for cancer, although that's not our primary target because we really want to focus on prevention, we haven't missed any cancers. So the sensitivity for cancer, reassuringly, is that if someone does have cancer, we're going to detect it. We're just aiming to try and find disease before that stage.
Sure.
Um, and then if we look at the positive predictive and negative predictive values, we're looking at about a 30 to 33% positive predictive value, which is expected based on the disease prevalence in this population. It sits around 10 to 15%.
Hmm.
And then the negative predictive value, which is the most important, is a 99% negative predictive value, which means that as a screening or triage test, we can be really reassured that those negatives are true negatives, which is not to be negative about Gallery, but it's a stark difference to the tests where the false negatives outnumbered the true positives. Here, the the number of false negatives are incredibly infrequent.
Hmm.
And then the things that I really like to highlight, so we did a few studies to look at the way that it's used in real world and the impact on provider decision making. But more importantly, I think to this audience is the impact on patient behavior. So we touched upon this earlier with the first case that we mentioned about the positive EsoGuard result finally motivating this otherwise non-compliant patient to get his EGD. That data was actually replicated in a multi-center study that we performed and published about a year ago, where we looked at the compliance rate of these patients who were EsoGuard positive that then moved on to actually getting their upper endoscopy, and the
Hmm.
compliance rate was 85%.
That's
And
great.
yeah, like that's a really good number for like, physicians who are used to dealing with patient non-compliance. But then in the literature, there was actually a study that was published a few years ago by Dr. Kolb out of California, where she looked at the standard compliance rates for patients who are referred for upper endoscopy. She collected this data from patient surveys from multiple centers. And a small number of patients were referred for EGD, but an even smaller number among those actually followed through. So about 13.5% of patients who met high-risk criteria were
Hmm.
referred for an upper endoscopy, and only approximately 40% of those patients who were referred actually went on to get an upper endoscopy. So that adds to why the screening is so infrequently
Right,
performed.
right. Currently, you cannot rely on symptoms to be your guide to go
Yes.
to the endoscopy.
Yeah. And a positive biomarker test can potentially double the patient compliance with these referrals, which I think is pretty remarkable too.
Yes.
And then just last before we wrap up is the topic of resources that we had discussed earlier. So as you can imagine, when you start screening more patients who are at high risk, there's potentially a lot more patients who are going to need upper endoscopies. And we did another study and published it last year to really look at what the impact on resource utilization is when you start implementing a non-endoscopic triage test. And when you think about an upper endoscopy that's done purely for screening purposes in this high-risk population, that upper endoscopy, the positive predictive value is going to be equivalent to whatever the disease prevalence is in that at-risk population. So this ACG risk population, the disease prevalence is somewhere around 10 to 15%. There was a meta-analysis that said it was about 11%. So we'll use that as our number. So we would expect that if we were to do screening EGDs on these high-risk patients, the positive predictive value would be 11%, because that's what the disease prevalence is.
Hmm.
Then we looked at our data for patients who got EsoGuard, came back positive, and then underwent their EGDs. And we looked at what the diagnostic yield on those EGDs were. And they ranged, depending on the cohort that we were looking at, from 25 to 30%, as we
Hmm.
would have expected based on the
Right.
positive predictive value from our other study. So we can see here that by using a triage test, you're increasing the diagnostic yield. We're increasing the positive predictive value of these EGDs by about 2.5 to threefold. So that really shows us that we're better tailoring the population that's undergoing these invasive procedures by increasing the pre-procedure probability of actually finding something meaningful.
So the patients that are in risk, if you do the system checker, you decide the patient it falls into the risk uh, GERD plus one, two, or three, um, and it comes back negative. When would you repeat the test,
That's a
the
great
EsoGuard?
question. So the guidelines currently don't have a specific recommendation for when they would recommend retesting. The ACG guidelines actually say that, if a patient is over the age of 50, they've undergone a negative screening test, then they don't necessarily get recommended to be retested because the likelihood of developing precancer and then progressing to cancer over the course of the rest of their lifetime is relatively low. However, we do know that if patients are initially screened at a younger age and they continue to have persistent risk factors, including reflux, obesity, smoking, all those other elements we talked about, the risk of developing disease really is there. So
Hmm.
the idea of never screening them again would miss patients with disease. And there was a VA study, another one, because the VA does so many wonderful studies with their population. Another VA study that was published about 2 years ago that looked at these patients who underwent a negative endoscopy and then followed them at 5, 10, 20-year intervals to see how many of these patients ended up developing Barrett's or esophageal adenocarcinoma. And the longer you waited, the higher the likelihood that someone would come back with new disease.
Hmm.
And the younger they were at the time of screening, also the more likely that they would end up developing disease over the course of follow-up.
Sure.
And so they show that for younger patients, rescreening at 5 years would find disease in maybe about 5% of patients. At 10 years, you'd find it in about 8 to 11% of patients. Within 20 years, that increases further. So that would definitely be something to think about from a physician's perspective of
Hmm.
how young they were when they were first tested and when we would feel comfortable, how long we would feel comfortable waiting, but definitely the rest of their lifetime is way too long.
Right.
With older patients, it looked like it kind of plateaued. After about 2 to 5 years, the number of patients who were coming back with new disease, that incidence rate wasn't increasing much further the longer you waited. So with older patients, probably a rescreening at somewhere around like 5 years might be sufficient to really be reassured that they're not going to develop disease. But these are patients that are over the age of 50. So either they could get rescreened once or not screen at all per guidelines, and chances are not too many of them will end up developing cancer. Any other questions that you think the audience might be
No, I
interested in?
think when I think this is important for people who are on chronic suppressant medication to start thinking about both their family history, looking at, I do a lot of GI work. We deal with a lot of SIBO, IBS, constipation. We also have a large practice of pouch patients. For rheumatologists, I deal mostly, I would say about a third of the practice is GI at this point. And the problem is that the gastroenterologists are basically endoscopists. And there isn't a cohort of people that I've found able to address all the GI issues medically. And I work with Dr. Sunny Jain in San Diego. He does GI mapping, custom probiotics. And so we've been bringing all of these technologies in. We do the breath test, GI mapping, we do gut barrier testing, we do uh, food inflammatory testing because we're always trying to, and I probably order more HIDA scans than all of the GI practices combined because we're looking at dysfunction in the gallbladder as a cause of chronic constipation because you don't have that bile transport and the 5% of the bile getting to the colon and stimulating. So we're always in the move it or or lose it. And a lot of these patients have reflux because their gut doesn't move. So they're in this position, they're like, they're constipated and then every time they eat, they're having all this reflux. And I think it is over time until I get clearing out the gut, it is putting them at risk. And if they have a family history, that's another trigger that, well, we should be looking. Or the other one that I'm noticing is hairdressers and nail salons. These people are exposed to toxic fumes for years, 40 hours a week.
Yeah, and all of those things are, as we mentioned before, it's hard to refer all of them to GI, especially if the average wait time is 6 months. So having a non-endoscopic test is really going to be helpful to figure out which patients truly need
Hmm.
to get those referrals without overtaxing our available resources.
Right, right. So I think this is a real help this technology, and it's going to move into kind of the same parameters we use for colonoscopy, pap smears, lung cancer screening, that providing screening that's non-invasive is the future, I think, of most of our cancer screening.
Agree.
So I really want to thank you for coming and speaking to us. This will be going out with our newsletter in December, and we'll start our system checker. I'll put it in the newsletter if you send it to me and let people
Yes.
start self-referring and getting in, and then we'll coordinate and having a tester here, which would be great.
Thank you so much for the opportunity.
So have a good Thanksgiving.
Happy
Don't eat too
Thanksgiving.
much.
And then I'll have reflux.
Yeah,
Or
to be quite honest, through all my pregnancies, I never had reflux. And what are these people talking about? Until I turned 70, I woke up and I went, "Ooh, is what everyone's complaining about?" Well, it turns out your acid production drops pretty, I guess, dramatically at 70. And I was thinking, "Oh my goodness." So I went on betaine hydrochloric acid and cured my reflux in about 24 hours.
that's a
So,
relief at least, but
yep,
also, I guess, something not to look forward to once we
there's a
hit that
lot
age.
not to look forward
Yeah.
to. Well, have a good one and happy holidays.
You too. Have a great holiday.
Take care.
Bye.
Thanks.